First of all, thank you, Naomi, so much for inviting all of us to share ideas around kidney cancer with this very engaged patient group of advocates, survivors, and caregivers. I think one of the things that's been emphasized across the talks is that here in Philadelphia, we are all friends, we all collaborate, we all want what's best for the patient in front of us. And if it's a clinical trial that Naomi has, we mention that and send patients to see her. If it's surgery that Dr. Uzo or Dr. Guzzo have, we sort of engage all of our team members. So whereas we do practice at different institutions, we are engaged really nationally and internationally, as you'll see with our speaker from Italy, around ideas to help everyone get better outcomes from their kidney cancer. So we're all in it for everyone. So what I'll talk about today is combination therapy for kidney cancer, but I'd also like to take this opportunity to talk about a couple of other things that we do. We, as Dr. Uzo said, engage with pharma companies around a number of things, around developing guidelines on separate guideline panels, around designing the clinical trials that you'll see, interpreting the data, publishing the data. So the sort of ecosystem of research and the energy behind new drug development is also collaborative, and that's why we have disclosures around our presentations and such. So what's been amazing to me over my career, I feel like I came into kidney cancer at exactly the right time. I started fellowship 15 years ago. I've been at Fox Chase for 11 years. I remember when the first VEGF TKIs were approved back in 2005. I was just starting. And since then, we have just really made strides in this disease. And this is just a graph I made looking at how we've improved the percentage of our patients who are alive at 2 years with metastatic kidney cancer. So these are the patients Naomi and I meet in medical oncology clinic and Dr. Narayan who have cancer that spread. We say, I'm sorry, we can't cure you, but we can control this. And when patients ask, well, for how long? I have an increasingly hard time answering that question because the numbers just keep getting better and the old numbers that we rely on are no longer relevant. So in terms of response rate, and I'll just describe what this is for a minute because we talk about this a lot. Response means a tumor is shrinking or not growing very much. We use it as a metric when we decide how drugs work and how well they work. And as you can see, we are shrinking more tumors than ever as we sort of improve upon therapies. We have more single drugs over here with the somewhat lower response rates, and you can see we've really augmented the percentage of patients whose tumors shrink on therapy through these clinical trials. Now, this is not the only metric. We want to keep people alive longer. We want to keep people stable if we can't shrink their tumor. We love shrinking tumors. That always feels good. But again, we sort of look at a number of metrics when we're measuring whether or not therapies work. And I'll try for this audience to kind of explain how we talk about this in the language that we use. But progress is being made, and it's been great, at least as part of my career, to see this happen and to be able to help more patients. So when we have a patient come to us with kidney cancer, one of the tools we have to sort of assess what treatment match is best for them are these IMDC risk criteria. And this is a beautiful graphic that actually IKCC put together and I use with their permission in many of my talks. And we look at 4 blood tests that the patient brings with them and 2 clinical parameters. So if a patient has none of these, they're considered favorable risk. They have a good prognosis. And actually, as I'll show you, we may select a different first-line therapy for that type of patient. If they have 1 or more, they're intermediate to poor risk, which is the majority of our patients, about 75 to 80%. So the things we look at is time from diagnosis to treatment. That means the patient who had their kidney out 5 years ago thought they were cancer-free, unfortunately had a scan that showed recurrence 4 years later. That's good that it took that long to grow back. It grew slowly. It's not good that it's back, but it's good that it took that long. And so when we look at that first parameter, that's what we're really trying to describe. Performance status is how sick is the cancer making this patient. And so we take that into account. And the other 4 are blood tests that we find are predictive. So this is a Kaplan-Meier curve. We've been showing a lot of them already, but I thought I'd take the opportunity to explain what this is and why we use them so often in medical oncology clinical trials. So here is time along the bottom, and here is the percent of patients that are alive. And this time point starts at as defined by a given study. So these are the risk criteria applied to patients who are newly diagnosed. And from diagnosis, as we march along the time frame, you can see, for instance, here out at 4 years, more patients are alive, meaning this blue curve is higher, the percentage is higher than with poor risk. And so what I sort of think of us as doing in medical oncology trials is just hefting these curves up higher, right? We just want everyone to be up higher, and the most beautiful curve would be one going straight line across the top where everyone stays alive for a long term. So as you're looking at these curves with us, hopefully the little tutorial will help orient you to what we're trying to describe with them. But this one in particular here is just meant to say, before we even had immunotherapy, based on those 6 characteristics, we could pretty much define whose cancer was likely to be more deadly and whose was likely to be what we call indolent, slow-growing, not necessarily immediately harmful. So let's first talk about favorable risk. So I'll present a case. Hopefully this is relatable to some in the audience. This is a 70-year-old woman with a clear cell kidney cancer. She felt absolutely fine until she noticed blood in her urine, which is common. The tumor on the kidney was found and promptly removed surgically by Dr. Uzo. And a year later, so beyond that 1-year mark, a CAT scan showed a single tumor deposit in the lung. So this was removed with surgery, and sometimes when we see slow growth and minimal disease, as some of you may have had experience with, even though we can't cure it with surgery once it's spread to the lung, we do that surgery to what we say buy time or defer initiation of systemic therapy or drugs. And we think that serves a couple of purposes, this deferral. One is, you enjoy that time off of therapy, off of side effects. You don't have to come to the center as often. We're focused on your quality of life. 2, we don't know for sure that giving you treatment, certainly after surgery, there's some data that it isn't going to help you live longer, so why expose you to those side effects? And 3, we're making progress. So by the time we may need to treat this patient, my bet at the time, which turned out to be correct, is that we would have better treatments to offer her. So after this was removed surgically, she got a year where the scans all looked clear, but eventually some small deposits started to become apparent in the lungs. And at that time, we elected, in conversation with the patient, to observe the treatment. Now this may sound crazy, right? We have all these new drugs I just showed you. We have things that can help shrink tumors. Why not do something? Why do nothing? And we hear this a lot. And my answer is we have to think about this disease strategically. We can always do something. We can always pull a drug out of our pocket and give it to a patient. But we don't want to do that unless it's going to meet our ultimate goal, which is helping you live longer and live better and live to see new developments in treatment. So again, as you heard with some of the adjuvant studies, again, we didn't recommend adjuvant to this patient. We don't recommend it. We can do it. It's approved. We can give you a pill and be doing something, but it's not the strategic move that gets you further along in terms of living longer or in terms of living better. And so I urge you to sort of think about this when you're thinking about treatments versus observation. They're all tools and they're all strategies that we use. So now she's 73 years old, and after slow growth of these tumors, we ultimately elected to start treatment because she had a new lymph node. Currently today in our clinic, we would have all of these options. At the time that we elected to treat this patient, we did not. But I would argue we may make the same choice today, and that is we elected to start her on a pill-based treatment, pazopanib, which has been around for a long time. And we started at a 75% dose because she was concerned about side effects. The disease was growing slowly. Again, we wanted her to feel well on her therapy if at all possible. So currently, we look to these 2 different approaches in favorable risk, pazopanib or a combination of axitinib and pembrolizumab. I'll show you both. Pazopanib is the one we use at Fox Chase in clinic as first-line therapy because similar to Sutent, which many of you have been on or are aware of, we get the same results. You can see these curves are the same, meaning not one doesn't do better than the other. But when patients told us how they felt on pazopanib, they felt better. They had less fatigue and less foot soreness. And so again, with our goal to sort of preserve quality, this is our agent of choice. Not everybody's, but ours. We know when we think about immunotherapy versus starting a pill, the approved immunotherapy, which is a combination of 2 drugs, versus the pill. The pill does better. It shrinks tumors better. We didn't expect that. We thought immunotherapy would do better. But when we look at the subset of favorable risk patients in the large trials, we learned that pill-based treatment is better, so that underscored our approach not to give just pure immunotherapy. And when we look at survival, remember these are Kaplan-Meier curves, we see here for favorable risk, the sunitinib, the gray bar, does about as well as the green bar, which is the combination. So again, it's strategy. This is why we chose this treatment first. And in favorable risk, the response rates are similar to the axitinib and pembrolizumab combination. This is a pill-based treatment and immunotherapy, and the overall survival is the same. So, you know, while we're thinking through all these therapies that are new and developed, we're also tailoring it to the patient, and in this patient's case, we still elected to use a pill. And the part of the question that we haven't answered when we think about combination therapy, which is the title of my talk, which I'm supposed to explain why we choose one over the other, is if we use immunotherapy with a pill first, what do we do next if it doesn't work? We've used immunotherapy, we've used the pill. We can answer that. We all have answers, and we've seen patients respond to things afterwards. But the question that we always ask ourselves, would we have gotten the same results or better if we used one and then the other, right? It doesn't, you know, if we use a pill-based treatment, we still have immunotherapy in our pocket. And I show you this data only to suggest that maybe we do still do very well when we do them sequentially. So these are patients treated with nivolumab or Opdivo and immunotherapy. That's the dark red bar up top, after receiving a pill-based treatment. This clock starts here at the time of their second-line treatment, and most of them are still alive. So maybe we can be strategic, give a pill-based treatment at a low dose, maintain patients, and then give immunotherapy, and that was the bet we made with this patient. So after 6 months, however, on the pazopanib, after I just told you how it's much better tolerated than sunitinib, she wasn't tolerating it very well. We had to reduce her dose. She had sore feet, high blood pressure, and the beginnings of some liver damage, so we elected to switch her treatment. I'm going to just mention one piece on side effect management. Too often, these pills are started at top dose. People feel terrible, and then they throw in the towel and either switch or switch to immunotherapy. These pills come in various strengths, and the top dose that we define in clinical trials is not necessarily the right dose for you as a patient, and so your doctor should talk to you about holding the drug, reducing the dose of the drug, and supportive care for your side effects. There is an art to how we give those, and I think at Experience Centers, I'm sure Naomi can speak to her strategies around this. Okay, so now our patient, we decided to stop the pazopanib because of side effects. We switched her to a similar drug, axitinib. She had had actually good tumor shrinkage on the pazopanib, and so we decided to maintain the same approach, but try for a drug that's a little bit better tolerated and also easier for us to sort of dial down in terms of dose. So she started this at a reduced dose. When we think of the next treatment, right, after we've chosen to stop the one we're on first, the options are many, and your doctors are thinking through all of these as they look to elect next-line treatment. I won't go over all of the nuances of how we think about this. Some of these choices have very good clinical trials to show us exactly what we think would happen statistically to a given patient. Some are inferred from other settings, but these are all things that we consider. So how do we think about it? And this is sort of how I frame it. If my patient has done really well on VEGF therapy, so a pill-based treatment with tumor shrinkage, cancer-wise, but you have to change it either for side effects or because they started to grow after years of control, I generally keep going with that same approach with a pill-based treatment. There are many different iterations, and we know one can work after another has stopped working. One can be better tolerated or have fewer side effects than the other, and so this is how at least I think through it. If the response to that treatment was brief, they got some control, but it went away, there is sort of thought that we could use a combination of a pill, in this case axitinib, with an immunotherapy, in this case pembrolizumab, in that setting. And the NCCN guidelines that we sit on reflect that. We think patients should have this option, even though there's really no data after you've had something else before. We think if they really work well together, this would be a setting where it might be reasonable to try it. If a patient had no response, no shrinkage, just growth of their tumor while they're on the pill, then we think about pure immunotherapy, either in combination or as a single agent, based on discussion with the patient and risk of side effects that they're willing to take. And then beyond that, once you've sort of gone through your first pills by themselves or in combination with immunotherapy, there is a combination lenvatinib with everolimus of two different targeted agents, a VEGF inhibitor and mTOR inhibitor, that actually can have some activity and work very well for patients. So this is a very broad strokes overview. There are many more options than are presented here, but this is how I think through selecting treatment for patients next. So I'm happy to say she's now 80. She has been on axitinib at this, we reduced her even further to 2 twice a day. Remember, standard dose is 5 twice a day, so we just kept going down. Her scans continued to look good, and she continues on this. So this patient had 10 years of disease control and counting. She has yet to see immunotherapy, which we have in the toolkit still for her, with observation, surgery to remove a metastasis, and these pills by themselves in sequence. So obviously, retrospect, hindsight is 20/20. We can say for this patient, the right choice now or then probably is to use one of these treatments for this long-term control. So what about intermediate or poor risk? So I'll present a different case. This is a 40-year-old man with poor risk or intermediate risk kidney cancer. He had an early recurrence after his surgery, and he had one of the blood tests that put you in the intermediate risk category. And he came to Fox Chase. We had the phase 1 trial of this combination of axitinib, it should say pembrolizumab there, axitinib and pembrolizumab. So he was started on that clinical trial. And this is now a standard of care based on his participation in the trial and subsequent patients who participated in the phase 3 trial. We know this treatment works, and those patients are reflected in the graphs that I showed you. But these are the options we look at: pure immunotherapy or the combination of axitinib with pembrolizumab. So we tend to favor axitinib and pembrolizumab at Fox Chase for intermediate and poor risk patients, again, based on these data. So you can see here in terms of survival, this green curve is clearly separated from the red curve, meaning patients on the combination, if you look here at 12 months, more of them are alive, 87% with the combination versus 71%. Now, not everyone has made it to 12 months. Some of them are earlier on in their treatment, so we don't know what these data will look like ultimately, but an early look is very encouraging. And we look at tumor shrinkage over here, the response rates higher with the combination versus the sunitinib. When we look at ipilimumab and nivolumab, this is pure immunotherapy. People also live longer on this combination than single agent, in this case sunitinib. And so for this type of patient, some sort of combination therapy is warranted and recommended, and this is what I think most centers would recommend at this point in time. So I'm happy to say he's now 44. He was on the study. He had near resolution of his lung metastases at his very first scan, which was maintained. The way the trial was written, the immunotherapy, the infusions ended at 2 years. We stopped them. That's how the protocol was written, and we didn't know that he even needed more of that. And after some axitinib to control it long term, we decided to stop that too because his disease was so well controlled. And so he's maintained off of therapy after being on this. And the patients and others like him who've been treated with these trials ask, well, how long will my cancer stay controlled? And the answer is we don't know. He's one of the patients who's had this sort of the longest time frame on this. He's at 4 years. I would say we need to follow these patients out to 10 years to 20 years and see if their cancer remains controlled. And then we can sort of change the conversation around treatment once we know long-term outcomes, if we can maintain control of disease that far out. So do we know if this will last? It's still early. Our patient has only had this, only been followed for 4 years, and that's one patient in a small study. Well, we do have earlier data combining nivolumab or Opdivo with similar drugs. These combinations aren't advised because they're too toxic, but the patients did really well. So because this is an older study, we can look back and see that now at 4 years, more than half of patients are still alive, and this is before they had access to all of the new drugs that I just showed you, right? This is going back to, this is a 2018 publication, but the trial was started in 2012. So we are clearly making progress, and a lot of this progress seems to be long-term. I'm delighted to say, and I'm sure Naomi and Vivek can also say, our clinics are packed because people are alive and coming back to see us on treatment or on follow-up, and we hope to just continue to swell those ranks with effective treatment. So in conclusion, until we can cure kidney cancer, until I can sit in front of my patients and say, we can cure this and this is the treatment I recommend to do that, we have to be strategic, right? We have to say our goal is to keep you around as long as possible, to see new treatments and to see milestones in your life, and to have that time be good quality time. We don't want to make the treatment worse than the disease with side effects from therapy. And these are the balance that we're constantly trying to strike when we treat our patients in the clinic. We consider multiple factors when a patient's in front of us, and we're working through all of the various options. How fast is the cancer growing? Can we observe it? Can we watch it without adding therapy? What is the risk category? I just explained how that helps us. Should we select a single agent drug or a combination? Other health conditions, of course, the patient's overall health may inform the relative risk of immunotherapy over a targeted therapy. And then what does the patient prefer? What's the patient's values? Some patients say, I want to, pile it on. I want to try everything. I feel better doing something, even after we explain all of this. And others say, what if I do nothing? And we can explain that too. And so everyone's probably somewhere in between or at either end of that spectrum. And our ability to understand what you value as a patient is critical. And we have to follow all these studies long term. So a lot of these answers we won't have until the courageous volunteers who volunteered for these trials when we knew very little about them, are hopefully still alive at 10, 20 years. And then only then will we be able to inform the new crop of patients in terms of what to expect. So I hope that was helpful. I hope that leaves you with some hope that we're continuing to work very hard together within Philadelphia and internationally to really improve treatments and also improve how we think about and strategize around each individual patient. Thank you.